Now very quickly we're going to see the plasma cell dyscrasias. This includes MGOS that stands for monoclonal gammopathy of undetermined significance, Waldenstrom macroglobulinemia, and multiple myeloma. We talked about this in previous videos. Here we are just going to do the comparison. So in each one of these we will see a increase in immunoglobulins. So we will have a M spike on electrophoresis, serum electrophoresis. For multiple myeloma, the production is with IgG or IgA, mostly IgG. Most common is IgG. For Waldenstrom, it is IgM, and for MGOS, IgG. Now, MGOS is completely asymptomatic. The only thing is that we will, in routinely or by some other reason, we found an increase in proteins, and so we will do the bone marrow biopsy in order to rule out multiple myeloma. And the treatment will be, well, just following up each 6 months in order to repeat the labs in order to see that the patient is not going through Waldenstrom or multiple myeloma, because this is a precursor of any one of these two, but also of chronic lymphoblastic leukemia or other lymphomas. That will also lead to a spike. Now, in Waldenstrom, because there is increase in IgM is a pentamer, so mostly will be symptoms of viscosity. Could be retinal occlusion, could have stroke, but also the increase in viscosity leads to a decrease in platelet aggregation. So also the patient will have bleeding, retinal bleeding, or a hemorrhagic infarction of the brain. These patients would not present with the crack findings as in multiple myeloma, so we're going to talk about them. And sometimes the patients have generalized lymphadenopathy. The treatment will be plasmapheresis, best initial treatment, but also rituximab and chemotherapy for patients that are symptomatic, not of viscosity symptoms. Sometimes we can use bortezomib, rituximab, lenalidomide, etc. Fludarabine. So in Waldenstrom we have a increase in IgM protein and symptoms of hyperviscosity. Now for multiple myeloma we have increase in IgG, IgA. This will be called the Venus-Jones proteins that will be seen in urine or serum electrophoresis. Remember that in urine the dipstick will not reveal the Venus-Jones protein, because the urine dipstick only detect albumin. Actually, the albumin will be a little bit decreased, so we will have increase in the gap of proteins. Increased proteins, usually more than 3 grams of only immunoglobulins, but the total protein will be above 7. And we will have a little bit of decrease in albumin, so for that the gap of protein will be elevated. Now the anion gap would be decreased because IgG is a cation molecule. The cation molecules increases the levels of chloride and bicarbonate. So this would lead to a decrease in anion gap. Anion gap is calculated as the concentration of sodium minus the concentration of chloride and bicarbonate. So because this number is increased, we will have a decrease in the anion gap, that is all this number. We will have Reulux formation. This is the stack of red blood cells, because there will be decrease in the negative charge of the red blood cells, so they can get stuck quicker, and we would look this as a increase in the erythrocyte sedimentation rate. Patients are prone to infections because this is a monoclonal production of immunoglobulins, so there is no functional immunoglobulins. The patient sometimes can have bleeding and anemia of chronic disease. Anemia that we will see in Waldenstrom would be cryoglobulinemia or autoimmune hemolytic anemia called agglutinin, because IgM can form pentamers that activate complement. And also we will have Raynaud phenomenon here due to the IgM pentamers being occluding the distal vasculature. So, multiple myeloma presents with CRAB, hypercalcemia due to plasma cells secrete IL-6, and IL-6 increases the expression of rank receptor or osteoclast, and so there are lytic lesions. Lytic lesions lead to increased release of calcium. Then the kidney could be damaged due to immunoglobulins. Also could present as the Fanconi syndrome in adults. Anemia and the Benz-Jones proteins that are not detected on the reactive urine dipstick, but do an electrophoresis. A normal electrophoresis looks like albumin, then alpha-1, alpha-2, beta-2, macroglobulin, and then the immunoglobulins. In any one of these three, the immunoglobulin is increased, so we have a M spike seen in electrophoresis that corresponds to IgM in Waldenström macroglobulinemia and IgG or IgA, most common IgG for multiple myeloma. So this would be the best next step that we will do when we suspect this. The first thing that we do is electrophoresis, and to confirm the diagnosis for multiple myeloma would be bone marrow biopsy. In bone marrow biopsy, we will see more than 60% of cells, the same as, well, certainly more than 10% in Waldenström, and in MGOS less than 10%. The treatment for multiple myeloma is, if the patient is less than 70 years of age, we can do bone marrow transplantation, but before that, we give chemotherapy that consists on melphalan, prednisone, and thalidomide. For those that are not candidates, we give dexamethasone plus thalidomide. And those that are above 70 years of age, we give melphalan and prednisone. Sometimes we can also give rituximab, bortezomib, and danuglipron, that is a monoclonal antibody. Bortezomib and lenalidomide or thalidomide have the adverse effect of neurological symptoms like peripheral neuropathy. So, multiple myeloma present with CRAB findings, IgG monoclonal spike of M spike, Waldenström macroglobulinemia with hyperviscosity, and a M spike corresponding to IgM, and MGOS is asymptomatic.